So tonight is kind of, what did we do the first night? Anybody remember? Foot, yeah. And then what do we do the second night?
Spine.
Back. So now what are we going to do? We're going to stuff in between. So we're going to do hip and knee, right? So we're going to get some crossover. It's going to kind of tie everything in beautifully. It's going to be amazing. So you guys all have your handouts. So we're going to get through this. I have a cutoff here. I think we were told we only had a half hour to do it. I think we go a little bit longer than we should. So we're trying to get it done in a half hour tonight. And then you guys are going to have to do our new movement challenge. Thanks for those guys that submitted the movement challenge out front of the store. This is a different movement challenge that is a little bit more challenging in terms of balance, but we're going to have you guys do it tonight. Maybe we can have some extra time. So when, does anybody come into your store and say, yeah, my knees bother me?
Yeah.
Okay, like a lot? Commonly? Okay, so what happens when that happens? What do you guys tell them?
What part?
What's that?
I'll ask like where on the knee.
Where? Sure, okay. Well, like, where's the location? And then when they say it's in the inside, what do you tell them?
I look at their shoes.
Look at their shoes. Great. Okay. And then what would be what is common thing that you see in a shoe of someone that has pain on the inside of the knee?
They might need to be in a stability shoe.
Okay. All right. So their foot is flattening out, putting a little bit of stress on the inside of the knee.
Mm-hmm.
Okay. Great.
Or an insert.
Okay. All right. So you're kind of looking at their foot structure and saying, hey, let's try this shoe or let's try this insert. Anybody do anything different?
Knee braces too.
Knee braces.
I
Okay.
moved them. PT's over here now.
Okay. There you go. All right, so we might suggest a knee brace, okay? And then what is the follow-up? Do they like email you back and say, oh my God, that was the perfect shoe and orthotic is amazing?
We don't get a
They don't follow.
That's
Well,
not really-
it's probably, hopefully because they fixed the problem and they don't need any more, right? So we'll just go with that because that makes me feel good. Okay, so that gives us an idea of what we're looking at. We're gonna give you a couple different tools tonight to start looking at the knee a little bit more scientifically and with a physical therapist's eye, right? So we tell you, if you followed us around for a couple weeks, you could probably do like 80% of what we do. And we really say that with authenticity because we need to be able to educate you guys on how to do this because we can't be here in the store all the time. We're very expensive. We can be here, but it's not good. We're going to like cut a couple salaries here. So first thing we're going to go over here is knee and hip evaluation, tissue impairments. So we're going to talk about the different tissues that are irritated that are common in runners. So Dakota, take the first one here. So meniscus and MCL. Wow, that was good. That's the exact thing we talked about here. So
I was going to say it's a perfect jumping off point. So when you're pointing to like the inside of the knee, most commonly I'm going to see people when they're coming in with running injury, knee injury, typically going to be on the inside of the knee, and that's where the meniscus and the MCL are located. Does anybody know what the meniscus does? What its job and purpose is?
It's a cushion.
Cushion, yep. So perfect. So every time that you're running and you're putting a lot of your body weight down, obviously through the leg, then you'll be putting stress on the meniscus. Now, most time people, when they complain of meniscus pain, it can be just that they're having pain there and that's it. But you can also have a runner that comes in and says, my knee feels like it clicks, or they feel like it catches, or it's popping and kind of catching, and they're having issue with that. Now that's going to be more of what's going to be indicated of like a more of a severe tear if they're really getting a lot of that catching, because what's going on is as their knee is moving, it's basically getting jammed between their femur and their tibia, and they're kind of locking up, and it's going to be hard to go through the rest of the range of motion. But if someone's just having vague pain on the inside of the knee and they're not having any of that, can be meniscus. Now, does anybody know what the MCL is? So the reason why these are linked together is because the MCL is what's called the medial collateral ligament. So what this is going to be doing is every time when Melissa, right? So she's saying that you're going to be putting someone in a posted up shoe. And we'll talk about this down a little bit further, but every time they're running, if their knee is collapsing in, basically what they're doing is putting stress on that MCL. They're stretching it over and over again. And as someone's running, a mile, they might get away with it, but 2, 3, 4 adds up to as many times as they're overpronating in the shoe, putting stress down on the MCL, and they're just leading to overstretching there. So really the goal of the MCL is to stabilize the inside of the knee, but if you're getting too much instability causing from the foot and putting pressure on the knee, that could be leading to an irritation there. At the same time, the MCL does attach onto the meniscus, so there can be some crossover involvement. That's why when someone says medial knee pain or pain on the inside of the knee, it's pretty much a safe bet to go with like either one, especially if someone isn't going to be having those catching, clicking symptoms. That could be more of a high-grade meniscus tear.
All right, so some people come in and say I have pain on the inside of the knee. Well, some people come in and say I have pain like right in the front of my knee. Anybody ever do that? Yeah, okay, so look at the next one there, because that's what is going to be the cause of that typically. If someone says they have pain right in the front of their knee, it's usually a patella femoral problem. So your patella is your kneecap, right? So if you straighten out your knee and you don't have the muscle on, you can kind of move that thing around, right? It's kind of creepy actually that you can move this etc. Right? So that thing sits in a groove, and it glides back and forth. In an ideal world, it sits in the groove and no problems occur. But what happens when we'll talk about single limb squat later, but when you don't have good alignment between your hip, your knee, and your foot, then that groove can be irritated, and it can sometimes even slide out of it. So a patellar dislocation is really rare, but what some people will complain of is just some pain in the front of the knee. Typically when they're getting a little bit more into their mileage, if they're doing hills, that's when they'll kind of bother it a little bit more, and especially if they say, yeah, I want to go up and down stairs at home, then it really bothers me. That's when they have like a patella femoral problem. But for the most part, if someone comes in and says they have pain in the front of their knee, you can pretty much diagnose them with a patella femoral issue, and then you can sound really smart, so remember that. So the correction for that is just kind of cleaning up their alignment. So it's just making sure mechanically all of this stuff will look similar, right? So the foot kind of pronates, the knee kind of comes in, and there's stress put on the hip. So this is like a movement dysfunction. It's the tissue that breaks down is like really dependent on, almost luck or bad luck in this case. Some people will come in and say, I have pain on the outside of my knee, some have inside of me, front of my knee, I have an inside of my foot, outside of my hip. All of it can be corrected with mechanical issues, biomechanical fixes that we would do in physical therapy. So with that, you'll also complain of kind of some clicking, so there's some kind of crossover. Then when my knee clicks, then it can be a meniscus problem or it can be a patellar femoral problem. That's where we kind of sort that out. But if they're complaining of consistent clicking, some people will have clicking with no pain. What does it mean if I have clicking with pain versus clicking with no pain? Does anybody have clicking in their knee, by the way? Okay. Like when do you get clicking in your knee?
Upstairs.
Okay, go up and
Well,
downstairs.
Upstairs on the house.
Okay, is it painful?
No.
No, just happens. Is that bad?
No, just air being released.
What's that?
Just air being released.
Okay, good point. Do you get it to happen over and over again, or does it just happen once and then it goes away? Every time. Okay, that's not a joint cavitation. Okay, if it's a joint cavitation, you guys ever crack your knuckles? Right?
Mhm.
That's a joint cavitation. When I crack my knuckle, can I do that again? No, I have to wait a little while, right? So that's what's called a joint cavitation. It happens once. Typically it feels good when that happens, then that's a joint cavitation. If you say like every time I go up steps, that happens, that's more of a tendon or ligament that's kind of rolling over a bone and will cause that click or pop. Most of the time it's not painful. So is that a real problem? I would say yes. It's kind of like a check engine light where it's your body's asking for some change. It's saying, hey, something's going on here. And you can typically get away with it. Like you walked in here tonight, you probably don't, do you have like much knee pain?
No, I have hamstring and
Okay, all right, so we got some of that going on. So it's an alignment, kind of mechanical type issue. It's causing some clicking. If you have clicking with pain every single time, that becomes like a structural issue that I would be concerned about. Okay, is there a meniscus tear in there? Is there something more significant going on in terms of patella femoral issue? But a lot of people have that clicking without pain. That, if someone says that, they're probably okay, but it's a warning sign of something bad might happen if you don't do something about it. All right, so let's talk about more up in the hip now. So Dakota, labrum and IT band, tell us about that.
Yeah, so with the labrum, we also have one in the shoulder. And I know we didn't talk about shoulders here in terms of the series that we've done so far, but really the purpose of that is to provide more stability for the joint. So it helps to kind of deepen the socket. And one of the reasons why is because our hip just has so much mobility. Now, has anybody here had or heard of the labrum or had a labral injury or been told or had a hip injury?
I haven't had one, but two of my college teammates had tears and
Okay.
had surgery.
Okay,
Labrum tears?
so
Yeah.
What sport?
Track.
Okay.
So I will say that it's not like the most common to have a
No, it
full
wasn't, but both
on.
of them did.
Yeah, I say it's not the most common to have a full labral tear. Now, what could be happening? I mean, again, that's going to be college athletes, going to be a lot younger, so that's going to be, less likely to, at least that from what I've seen. But what can happen if you have like a run in their middle age is they're still going to have like deep, vague front pain, can be kind of the side as well, but it's going to be like a dull burning pain. That's what people are going to complain about. They're like, yeah, I get it. Again, it can be any length in time. It could be short duration, long duration on the runs, doesn't matter. But what can also go along with that is bone spurs in the hip. So they sometimes will say, yeah, it doesn't feel terrible when I run. I feel like I can't stretch and extend my hip, so when my leg is going to be my trail leg, feels like I'm getting a lot of pulling in the front. Or they say gets really stiff if I'm sitting down for a long period of time and they go to stand up, they really can't extend that hip too well. They also can get pinching pain. So like, oh, one leg I can sit pretty easily like cross-legged, and the other leg is like, I can't do that. It's lacking mobility. So that's what someone will complain about. It's typically front or anterior hip pain with the labrum. And again, it's just more for stability. So similar to meniscus. So the meniscus, you can, yes, wear down if your mechanics are bad, and same thing with the labrum. So that's one thing when you guys have runners to go over is they do a lot of research that runners have increased cartilage size, increased muscle fiber size, increased tendon size. So not running alone isn't a risk of injury. I know Travis said, like, yeah, how many runners are going to walk in here and have an injury? It's going to be most of them, right? But it comes down to the things that you guys can give them. So more of the alignment tips and tricks, talking about running volume with them. So there's a reason why you have a lot of runners that can go at least for a long period of time without having injuries, and then some that just get recurrent injuries because they're not doing the proper things to basically clean up some of the issues. And that's what we're going to be talking about a little bit later. So I know it sounds like scary, like, oh man, we talked about all this stuff so far, like this can go wrong, and it's very similar. But at the same time, people, and you find this, like runners, Travis and I try not to ever tell someone to stop running unless they're really, really in bad shape because it's just really obviously healthy for you. So for whether it's a musculoskeletal injury or some other type of injury that's causing them irritation, they can't get back to running. So that's just one thing I wanted to say, at least before we kind of go forward, is that it might sound daunting to have all these issues, but in the end, running is going to make you stronger, especially if you're doing it properly and you're doing some of these things to take care of your body. So
yeah. All right, so next is etiology. That's your Scrabble word
You
for
have a
tonight.
question?
Oh, go ahead.
May I ask a question?
yeah.
The labrum, what is that connecting?
So the labrum does have some connections into the hip flexor, but really what it's doing is it's sitting around the rim of the hip socket. So the rim of the hip socket is called the acetabulum, and then you have the femoral head that's going to be joining up that ball and socket. So it's basically going to sit and be a suction cup. So one analogy that we like to use a lot is, have you ever seen like a shower hook that you push onto the wall that will like hold like a towel? Okay, so that's really what the design of it is for. It's basically to keep more stability through the hip. It's basically acting like that suction cup. So if you have a tear in it, and especially if you have more of a significant tear, it's going to be hard to use that suction cup to stick on the wall, right? That's an analogy that I think everybody can kind of relate to, right? So that's the purpose of it, is basically if you get a tear in there, some people, again, you're going to have decreased stability, and that's going to lead to possibly arthritic changes because now you're trying to fill up that gap where that labrum once was, okay? Good question.
Yeah, any other questions? All right. So etiology, this is kind of like what causes runners to have problems or anybody to have problems. Poor posture, repeated microtrauma. That's what we treat all day long. So people, runners, I'm sure most of the runners that you talk to that have problems, it probably isn't like, yeah, I started running last week and I started having injury, so I came here to get a shoe. It's usually they've been running for a long time and then they have a problem. So typically, if you are doing things in poor postures, doing it thousands and thousands of repetitions, you can get away with it for a long period of time. And then there's one time where you push your run too long, which we've talked about, where you have some breakdown. And really, we've talked about tissues that can break down, but it is really a movement dysfunction. So the one, like, number one way that you can kind of take a look at mechanics when it comes to running and 3 to 5 times your body weight coming down into your foot when you run is that single limb squat. So I'll wake you guys up and stand up a little bit. Who thinks they have like hips that are on the weaker side that aren't that great? Yeah?
I got
Oh
one.
yeah.
Yeah, you can't do that.
You can't do this. Someone's got to come up here.
I'll take it.
All right, good. Now she's taking her shoes off. It's making it even harder. All right, stand here in this blue. All right, so everybody stand on your weaker foot if you got a weaker leg. Okay. We're gonna do is a single limb squat. Okay, all you're gonna do is try to get lower to the ground. So from here, you're gonna squat down, good, and then come back up. Okay, do that one more time. Everybody, do that one more time. Look at your knee and look at the relation to your foot. Okay, and then come back up, and then we're gonna look here. So everybody, look here, and you tell me what happens when she does that. What do you see?
Goes out.
What goes out? I think her knee goes in.
Yeah, it goes in.
Yeah?
On the down portion.
Yeah, so when you go down. So here's what you want to have happen. So when you're looking at somebody, what you want to see is, first of all, if they can't stand on one foot, like you'll get somebody that won't be able to stand for like 4 or 5 seconds, like that's a problem. We got to like start from somewhere else. You're not going to say, whoa, we do not need to run. Do not buy any of these shoes. That's what we're not going to tell you to do. But we're going to say, like, that's an issue. Yep. But you should be able to stand on one foot. Hey, you're going to wiggle a little bit. That's fine, right? You're going to move a little bit. But if you like actually can't stand on one foot for more than 5 seconds, which is more common than you think. Like, did anybody just check out their balance since we've started doing this and just stand on one foot when you're doing shoes? Awesome. Okay. That will tell you a lot. Okay? You want to accelerate that. Now get them into a single limb squat. What you want to see is you want your knee over the outside of your foot, and you want your foot to stay pretty stable, and you want your pelvis to stay level. So if you head up belt, what's that?
You want to go that way.
Yeah, so don't like, you don't want it to look like this, but yes, you want, when I look down at my big toe, I want to be able to see my big toe. But what happens a lot is sometimes if my knee comes in, my big toe disappears. Okay? So that's what you want to see. And you want to see your pelvis stay level. So the other thing that happens here is as you get down lower, some people can kind of fake it. So they'll get here pretty good, they'll keep their knee out here, and then what'll happen at their pelvis, they'll kind of drop their pelvis. Okay? So your pelvis has to stay level. So if you ever like level something at your house, like put, all right, there's a lot of leveling that went on here, hopefully. I didn't put it in. But if you wanted to level that, think about that as being on your waist, and as you go down, that should stay pretty level. If you can't stabilize that, which we'll see a ton, where people will kind of lose it at their hips, that means their external rotators are weak. They can't control their femur. Right? So when your external rotators don't turn on, and you can't control your femur, you're gonna look kind of wobbly when you do that. And so evaluating that on someone and kind of taking that barefoot, what will make you guys look really good is when you take them barefoot and then you put them in a shoe and you have them do it. It's like, wow, that really helped out. So the shoe can be super helpful doing that, right? I would argue, and so with Dakota, we probably want to look at that and take a look at why can we not stabilize in a single limb stance in barefoot, because a lot of people are spending a lot of time barefoot. They're not spending all their time in a shoe, so that's kind of important, especially if they're having pain. Then that's something that is typically, they'll try to kind of run themselves into fitness, right? So they're trying to solve a medical problem with a fitness solution. Sometimes that works. Like muscle activation is big. Like if we're lost, doesn't happen much, but every once in a while we'll get a patient and me and Dakota, I don't know, man. And you know what always works? Just get them stronger. If you just get them stronger, then it will fix a lot of problems. So that can help. But if you're having if you're having pain that is occurring doing normal stuff, then that's something you got to get fixed. All right, that was awesome. All right, so use that. Just look at, so it's 2 steps, right? It's balance, right? Let me just see if you can balance. If you can't balance for more than a couple seconds, that's an issue. And then if you can balance well, let's look at single and squat. It's just mechanics. So it's just, can your knee stay over their foot, and can their belt stay level, and their foot is not like going all over the place. You guys can do that. It's really simple. Make sense? All right. Anything else in there? I mean, in order to control your femur, you've got to get your external rotators turned on. There's a ton of exercises, and we've actually making up some rack cards. Sheena, did you get that example that I sent you? So I texted you a rack card today. So what Sheena wanted was...
Oh, I left my phone at home.
Okay, all right. So what Sheena wanted was, hey, I need a rack card that kind of gives me some information that will push to some more information on our website about foot and ankle, back, and hip and knee pain. So we have those tools for you guys. One, go and look through them because that will kind of help you out in terms of navigating what if people have questions. But 2, it's just good information. It's like, hey, you know, you're having a problem. We taught you guys how to evaluate this stuff, and if they have like a hip problem like that, okay, here's the hip card. You can give them this, and there's a ton of great information on there to kind of help you guys out with that. Because again, we don't expect you guys to like treat these people. We can give you tons of exercises, and no doubt they've gone on the internet and already looked for a ton of exercises. Some of them are great. Some of them are doing the opposite of what we're trying to do. So that's a battle that we're going to get. But these ones that we're designing for you guys will help you out with that. All right, evaluation, gait analysis, Dakota. We're going to watch these people walk. So you guys are already watching people walk, which is great. What kind of advice do you want to give them for, or what to look for when watching people walk?
Yeah, so it's going to be the same exact things. This is what makes this really easy. So Travis said you can always follow us around all day, learn our job. Again, it's going to be the same techniques that you would look with maybe more of a static dynamic, just single leg movement. Just apply that same thing to walking and running. So if you're watching someone run, and like Travis said, you're watching them from behind and their hips dropping, okay? Every time that they're doing that, they're going to lose some type of either hip stability and or knee stability, or probably both, okay? That's going to be the first thing you're going to want to watch, or what we call medial knee dive, okay? And the more medical term is going to be knee valgus, okay? So that's when we were having single leg squat, okay? That's really what we're looking for. So we're talking about that medial knee dive. Now that same thing can again happen with running. Someone plants, now they're spending a short period of time on one leg. They're either over-pronating, maybe the hip external rotators are weak, and their knees collapsing in, okay? So the same techniques that you would use for the single leg squat, same things that you can watch there, you can apply those to watching someone run or walk. Typically for a runner, you're gonna have to see them run because they should be strong enough to at least not go through those movements when walking. But again, you're still applying the same techniques. Should be a lot of overlap, pretty easy there. We already did the single leg squat. Now I know Travis said, you know, if you have someone, they're really shaky with this, you're probably not gonna feel comfortable going to that single leg squat, that's okay. But one thing you can also do is just see them regular squat, okay? Yes, they should be able to do some kind of variation, but again, everybody has their own, you know, comfortability with some of these movements. But you're gonna watch the same thing. So when they're gonna come down, and you're gonna see, okay, do they shift away? That could be either some, you know, either like an ankle range of motion limitation, hip, okay, but what you're also gonna wanna see is, are their knees doing this? okay? Are their knees going too far out? Can they even get down to a deep squat? So I know we had the deep squat challenge. Like, are they even able to get through that range of motion? So I can tell you, again, mobility or stability, things that, again, might be more than what they're going to get from here, but you still can use that as an evaluative technique for the same thing. So looking where their knees go. I know when I have elderly people that come in, and I know most people that are coming here are going to be at least active, even if they are older. You can still do, again, you can still apply some of those same techniques though. So it's pretty simple. It's, again, a lot of overlap. Just apply it to what you think the person is comfortable with, and if you ask them if they're not comfortable, then you have a way to kind of regress that movement pattern, okay? And the next one on here is going to be for a seated single knee to chest or a seated figure 4 pose. So this will be relating back up to the labrum. So if someone says they're having hip pain in the front, and again, they're having more of that pinching. So if they're, they don't feel comfortable doing it standing, they can either do a standing kind of single knee to chest, or they can just do it seated. That way they're already going to be in a little bit more comfortable position. Or for the seated figure 4, they're going to be basically sitting like this. And some people, on their one leg, they'll be like, oh, I can really get my leg down. And the other one's be like, yep, I can't bend it further because I'm having all this hip pinching, okay? So that's something that you can use to kind of say, hey, I think this might be going on. Now again, you can still fix some of that if you take pressure off the labrum by giving them, pointing them towards, I know Bruce said you guys got a lot of traffic on the hip strengthening series, so I don't know if they want to send them there too much. Do you guys still have those, like, videos?
Yeah.
Yeah, and I know you said that they were a huge hit, so you can send them that way, right? Try to give them some exercise. I know I went into pretty good detail for everybody on there with like reps and sets, like how much to do. So that's an easy way that you can get them to really just take pressure off the labrum. And that's really the goal. Is you're relying on something that's trying to give the hip more stability because you lack the stability through the muscles. So that's really why that labrum can be irritated. So that's another way to kind of say, hey, this like pinching in the hip, try these exercises, okay? Or send them to the rack guard, okay? We're gonna get you guys one of those for the hip and knee, and that's gonna give you them very similar exercises and another tool for them to use.
All right, quick fixes. So the stuff you guys are really good at is finding shoes to kind of support their arch to get them in better alignment. So you guys know how to do that. Single leg reach. So let's go through this, Dakota.
Yeah.
What can they do to try to help with some activation?
Okay, so really I was trying to pick some different things because again, we did have a lot of overlap up on the top, more of the evaluation, the etiology, but this would be more similar to an exercise that I did with the hip strengthening series where someone's going to stand on one leg, they're going to kick one leg back, and they're going to try to reach out as far as they can go. So usually you can use like a foam roller or just a target to basically aim for. During the hip strengthening series, I did what was called a single leg RDL, where you held a weight and you did the same thing. You're trying to kick one leg back. You're just trying to keep everything nice and aligned. Your back nice and flat, coming as far to the ground as you can, and back up. So again, really using a lot of muscles you still should be using when you're running. So ankle stability, that single leg stability, dynamic hip stability. You don't want someone coming down and doing either one of these or one of these, dropping the pelvis either way. So that's something that you can say, hey, like spend some time just in this position, because you do spend a lot of time obviously on single leg. So that's one thing I think a lot of runners don't do is they don't train single leg even though they're doing a lot of single leg. Like I do give my runners squats to do when they come in, but I really give them a lot of like lunges, single leg things, because that's where you're going to expose more of that weakness. They're probably going to be able to do a squat, and if you just did that, you're like, man, that looks pretty good. But getting them to do more high functional things, that's where you're going to really expose more of that weakness. So that's really what you can be giving them there. So just any way to spend more time on one leg, anytime, that's going to, again, show them where they're weak. And like Travis said, then you can give them the shoe, spend some of that time in that shoe as much as out of the shoe.
All right, let's stand up and do this. So if you guys do this now, you're probably doing it. You got to spread out a little bit, because what it's going to look like is you're going to get your leg behind you. So make sure there's nobody behind you. Okay? So you're going to pick one foot, and we'll typically, at the clinic, we'll have like foam rollers or something for them to reach to. It could just be a chair. It could just be a counter, right, for a patient. So go home, get in single limb stance. You know what good alignment looks like, right? So they can't do this, reach like this, and then have like really crappy alignment. So you're going to watch them do their single limb squat, so knee over the outside of the foot, pelvis level, and you want this motion to come out of their hips. So what's going to happen commonly is people will reach out of their back and they'll go like that. That's not what it looks like. From here, I'm just tipping over. My chest is coming forward, and all this motion is coming out of my hip, and I should be able to reach out in front of me and control that motion. If you have someone that can't do that, they're really going to struggle if you're going to ask them to run like 5 or 10 miles. So they need to be able to have this baseline kind of hip strength in order to do that. If you're standing on your right leg, you're reaching with your left arm. Okay, that's an important thing. Sorry, I should have said that first. Opposite. So if I'm standing on my right leg, I'm reaching with my left arm. If I'm standing with my left leg, I'm reaching with my right arm, so it's opposite, right?
Wait, so the leg that's extended, the same arm?
Yeah.
Correct. Yep, that's another way to put it. Yeah.
Huddle. Huddle.
Oh,
Everyone.
wrong arm.
So we did a team huddle in the morning, so the next one after, okay, guys, squat down.
We've
squat.
done
There you
like
go.
planks and talked and.
All right, that's good. Then you can use this one.
We tried getting.
That's why I don't work the early shifts.
The skills, but
Yeah.
customers kept on coming in.
Yeah,
Oh.
so but we were hoping that maybe we could do it together.
How about that? That would be awesome. Yeah, we'll put you on our Facebook page. So that's a good exercise just for strength and balance. It's a really good warm up too. So if someone's going to go out and do some running, doing like 5 of those on each side. So control the motion out. Should take you 5 seconds to get out. Hold there for 5 seconds, and then 5 seconds to get back. That will kind of turn on the external rotators of your hip as long as you're doing it in good alignment.
Are you laughing at me, Melissa?
Wrong arm.
So kneecap and hip is down, right?
Explain that.
So if you're doing this, the kneecap's supposed to be
So you
facing
should,
down,
there shouldn't be
not out.
any rotation.
Yes, yeah. So this part of your leg would be flat to the ground, right? So you wouldn't be out like this, and you wouldn't be kind of
feeling
in like
your
this.
hamstring, yep.
You're trying to keep in your pelvis level, and then just kind of coming forward. If I'm on my right foot, I'm reaching with my left hand like this. And I should be able, if I'm running a lot, I should be able to hold this pretty easily for a long time. All right, so we don't like to give things universally, but man, I don't know the last time I got someone on a table and said they had like a long hip flexor or a normal length hip flexor. So hip flexor is the muscle that's here. It flexes your hip, right? Not rocket science. Why is this muscle so tight and short, do you think? On everyone?
Sit a lot.
Yep, exactly. So even with people that stand a lot, like we try to sit you'll very rarely see us sitting in a clinic. Because sitting is, this is, I'm sure you guys have heard this, but sitting is the new smoking. So it's kind of overused, but there's a lot of truth to it. Like there's nothing good that happens when you sit. When you sit, just everything from here to your hips just shuts off, and then you're resting on your ligaments. And that's like a whole other talk. But for the most part, almost everyone would benefit from some hip flexor lengthening. So Dakota, what are easy ways to do that?
All right, so 2 easy ways. You can either do standing, where you're going to have one leg back, you're going to lean forward, and with this, you can either have your heel on the ground or you can keep it up off the ground. Either way, you should really just feel a stretch in the front of the hip. That's one if maybe someone doesn't feel comfortable kneeling, but I prefer kneeling because what a lot of people will do when they stand is they'll arch their back and they'll do one of these, which you're really not going to get that deep stretch. So it's easier if you get someone kneeling. Their first initial reaction is going to be to lean forward again and do that. But what you can do is cue them to really squeeze their glute on that side and then press their hips forward. Now, if I go this far forward without doing that, now I start to feel a stretch. But when I activate and really rotate my pelvis, I lean forward. I only have to go that far, and I feel the same amount of stretch. So this amount of motion compared to if I relax, that amount of motion. So a lot of people, that is the number one exercise I see people do wrong every single time is they'll lean forward. They're like, I don't feel a stretch. That's because when they're doing that, they're basically blowing through where they should be feeling the stretch because they're taking some slack out, like onto it by arching their back. Okay, so they're basically taking some stretch out of there, and they're like, I don't really feel this. And you do this one little thing, they're like, wow, I feel that a lot deeper in the hip. So that's a good way to get people, again, with the kind of the poor posture or repeated microtrauma back up there. That can even relate to sitting. So if someone's sitting all day and they go out and try to put some mileage on, and now they're feeling this tension in the front of the hip, giving them just that to be like, all right, do that. Remember, we talked about more of a dynamic warm-up before and stretching after. They can still do some type of, again, dynamic warm-up, the things that Travis said earlier, then afterwards really just stretch out the hip. Or just try to do that throughout their day if they're able to. They're not going to go out and run right away, but at least they're keeping that muscle loose. Okay, I know that's one thing I try to do when I'm working is stretch as much as possible. We're standing most of the day, but I'm still trying to stretch. So that's just an easy kind of tip that you can give someone. It doesn't have to take a lot, just 30 seconds a few times throughout the day. It's going to add up. It's just the little things. So
you can't do the dorsiflex and the hip stretch at the same time.
yeah, it's going to be hard because then what you'll do is, you really can, but it's a different way of doing it. For me, when I'm doing this, I have to lean a lot forward, more forward, and then you're going to get out of that. And what you're also doing is you're basically taking yourself and going that direction for the dorsiflexion stretch versus I have to keep my chest up a lot higher to get the hip flexor stretch. So that's what you'll see as a difference is I'm bringing myself down because I'm creating more of an angle with my ankle, and then I have to keep my chest up higher to get more of the stretch in the hip. So it is a little bit different. I know that gets confusing too, which is also why I like to do more of the half kneeling stretch. So it's going to be a little bit easier.
And so 2 minutes for real changes.
Mm-hmm. Yep.
Good point. Anybody have any questions about anything we've covered so far? This is the time to ask.
Did we do IT band? I think we skipped.
Yeah, it was-
Let's do IT band.
Yeah, we skipped IT
All right.
band. We went from labrum to etiology.
Okay. All right. So what is the IT band?
it's small.
Okay. Can we stretch that out? That's pretty easy to stretch out. We got no.
Yeah.
Okay. That's not gonna. Well, it would be hard to do it. Okay.
Yeah, I do
Okay.
that sometimes.
All right. So the IT band is connective tissue. You can't stretch out connective tissue. And it's attached to the tensor fasciolata, which is a muscle, but that tensor fasciolata is about this long. Okay, it's up here. Most of that is connective tissue. So if you're having an IT band irritation, what do you guys tell people to do?
Roll it out.
Roll it out.
Go to
Okay.
Robbins.
Good.
Second beer free.
Strengthen your glutes.
If you do soft tissue mobilizations for the IT band and it's a fairly fresh injury, you might get some success. But for the most part, that's a mechanical issue that you have to kind of clean up. That's not, the pain is presenting there, but it's kind of all that mechanical issue stuff that we talked about that you have to clean up in order for that to go away. Typically, if you have somebody that has IT band, they typically don't have that for like a week or two and then it goes away. Like someone will say, I've had IT band for like 10 years. I don't know. It's just kind of normal if I run. So it's because they've been running in poor mechanics for that long a period of time and the tissue gets inflamed and it's hard to correct. So there's no amazing like thing I can give you to do to fix an IT band problem. You will find people that have success with some of the typical things. I stretch it out. I would argue they're really not stretching out their IT band. They're probably mobilizing some other soft tissue that's kind of loosening up and taking pressure off of it. Because it's connective tissue. Like I can't. It's really hard or impossible to change the length of my Achilles tendon. Like I'm not changing the length of that. I can change the length of my calf that's attached to it, but the calf muscle is really long, so I can have an effect there. Your tensor fasciolata is tiny. Like it just doesn't work that way. So I'm sorry, that's definitely not the answer you wanted to hear. But was there anything like specific about? I'd like if someone comes in and complains of it, or like what answers do you want for IT band stuff?
Well, I saw it on here, so.
Well, I have a question.
Yep.
So when people say IT band, I'm like, oh, do you have a foam roller? And I've had success. I had a guy that was training for a marathon. He could barely even walk. And then he came in, got a foam roller. He came to see me 3 weeks later, and he did his marathon. He said, I foam rolled every morning and night, and I was able to run it. And when he came in 3 weeks previous, he couldn't. So what did that foam roller do to him then?
I would argue it mobilized some other soft tissue, and there was
And
more
then
like a
got
neuromuscular feedback, like a more kind of like when you do a joint mobilization. Yes, the joint moves, but there's something that goes on between the nervous system and the brain that will take really long to explain, and we actually don't even know a ton about. But I would argue it's more something like that. Now, if you
Or do people think they have IT and it's something like it helps me, I think, but maybe it's not IT. Maybe I'm having something else.
yeah, it's probably more there might be inflammation that's sitting around it that you're causing with poor running mechanics, and then the off chance like that mobilization might push it out. But you're not changing any of the IT band tissue. There's not a lot of like changes that are going on. But if
Yeah.
you do it and it works, then great, do that. Okay, so we're not saying that you shouldn't do that. If you stood on your head in the corner, got rid of your IT band problem, I'd say do that. Like physical therapy, right? So it's whatever works. But you'll find more stories of that not working than working.
And I also think I tend to agree with Travis on the idea that when someone goes to roll, foam roll or IT band, or if you've ever foam rolled, it never feels comfortable just to do one spot over and over again, right? So you're always changing. My guess and what I've seen that people do is when they say, oh yeah, foam roll your IT band, they're actually gonna get a little bit of the quad on the outside, so that could be tight, okay? And that actually is gonna be, again, making more of a mechanical difference for then how they're running, and that's going to, again, alleviate pressure. So what's gonna be happening is that the IT band is gonna be laying over top of the lateral quad and then also the lateral hamstring. So they might do some hamstring stretching. They're also gonna do some foam rolling there because they're gonna basically try to do both sides, right? They're not just hitting one spot over and over and over again. And they're loosening things up around it, just take some pressure off. And if they, again, are doing other things to help alleviate their pain mechanically, those are, I would say, more the reasons why. It's not going to be that they're just going to do that and now their IT band feels better. I think it's more of the other stuff that they're doing on top of that. So yeah, they're still foam rolling over it, but you also can't just isolate on a foam roll. I mean, a foam roller is huge, so you're not just going to be isolating onto your IT band. It's going to be more of everything else around it as well.
Yeah, you're going to get better results doing a single limb bridge to get activation of your glutes and your glute medius, because your glute medius attaches into your TFL and it will kind of pull that back. So if I do both, like for the most part, foam rolling is not going to hurt anything.
That was gonna be my question.
yeah.
'Cause I've read some articles that say don't foam roll.
Yeah, it's like super
CIT
thin
band.
and fragile.
Yeah,
I don't think it's fragile. It's
I wouldn't say fragile.
I wouldn't say fragile.
We've never
Like,
nobody comes in
like,
with a torn IT band.
Yeah.
There are some people who
I know
argue
people
that-
say like don't do it at all. Yeah.
Yeah, I've read some articles where it's like, yeah, you're not doing anything. It can, if anything, it's only going to hurt you more than it's going to help you. So that's helpful to hear that you're saying it's not going to hurt you because
Yeah, I haven't
we've
had
told a
this
lot
one.
of people over the years to foam roll.
Yeah. So well, guess what?
You gotta sell foam rollers.
Yeah, we
So they're gonna figure it out pretty quick, right? If they get on a foam roller and they flare that thing up, they're gonna be like, I'm not doing this shit. But if you do it on a foam roller, oh, I did it and it felt good. Again, there's like.
Or the percussion. Now I
Yeah,
just drill.
So it's all this stuff is n=1, right? So you're looking at studies and like subject size and like, oh, we did this study with 5,000 people and the majority of the people benefited from this. Well, if I don't benefit from that and I benefit from the opposite, I'm gonna do that.
Yeah.
So I'm more on the IT band stuff. I'm more for like let's just do single limb bridges and get the glute medius to kind of pull that muscle back. So I would give them both. Sometimes you got to give people what they want and then teach them what they need. So if someone comes in and it's like, I'm getting 7 foam rollers, let them buy them, and they can keep them in all the different parts of their office and do whatever. That's fine. But then I'm like, you know what? Do that. Great. I just need you to do this one exercise so I can get this muscle activated so I can pull that thing back. And people will come, oh my God, that electric stim, that was amazing. That's what fixed my problem. I'm like, no, it didn't, dumbass. But it's fine if it keeps you coming in and I complete your plan of care and I do all this other crap and that stuff works, I'm fine. I don't care who gets the win as long as you're better.
So what would be a good indication for us to be like, oh, that's probably IT band? Like, you know, he went through. Like, where's it present?
It'll be pain like right down the side of your leg.
Yeah.
But the IT band is not the only thing that's out there. Like it could be a nerve irritation, it could be just other tissues that are irritated besides the IT band, and it can be the IT band. Like there is diagnosed, like if we did an MRI on IT band and it's flared up, like that does happen. But the fix for it typically is not like a lot of foam rolling, but it can be, but it's typically not in our experience.
Yeah, they can have they can have IT band pain anywhere down the knee. Typically what I see, or down the leg, they'll have it like outside of the knee or up near the hip. They can have it in between as well where it spans, but those are going to be the two areas. They can feel like that clicks as well on the outside of the knee. That can be another thing that's clicking out of the many various things that can be clicking around the knee. So
They'll have a breakup
Yeah.
adhesions prior to doing your strength routine.
Yep. So just kind of there is value in kind of breaking up inflammation adhesions as long as you're not flaring it up. So does that clean up? Is that the issue that's going on, or is it just kind of prepare the tissue to get better performance once you do the strength training? It's hard to tell, but yeah. All right, go ahead.
Big dog?
So, in Sue's example with the marathoner, it could be too, if he was 2 or 3 weeks away from the race, he probably likely scaled back his training.
Could be.
And was healing
Yeah.
anyway, and with the addition of the foam rolling, that was enabled him to get through the race.
Yeah.
So it could be just back off your training and try some different.
But still sell them a foam roller.
Yeah.
So the important thing is he did his race, right? So that's the important thing is we kind of get these people better, fix the problem they came in for, and how they get there, isn't always easy to track, but as long as they get better, that's the right thing.
What does someone think, like when you give someone a foam roller and they ask, or you're going to try to sell them a foam roller, because Bruce wants you to sell foam rollers, what are you telling them it's doing? Like, I'm interested, I'm curious. What are you telling them that what are they going to benefit out of that?
Stretching. Stretching.
Stretch.
Good.
It brings blood and hydration.
So
and
that's like the
brings
biggest part.
blood.
That's what I think, possibly along with that, where they're scaling back their running, so they're taking a little bit of tension. They're, running or any exercise is pro-inflammatory. So we're creating inflammation there. Now he's doing 2 things, that marathoner in that case, doing 2 things to reduce their inflammation and heal prior to that. So they're doing the laying back on training most likely as they're tapering into that marathon, but now they're doing something that's going to be promoting blood flow and promoting healing and change to the area. So not only are they getting some stretching benefit that's going to make their body just feel better, okay, like Travis said, it's kind of like the placebo effect. They just like now it feels better. But they are doing mechanical changes. So that's the one thing that whenever I try to tell someone about what a foam roller is doing, it's basically giving yourself almost like a self-massage. It's hard to inflict pain upon yourself, but if you can suck it up for the short period of time that you're able to do it, you can have neurophysiological changes there, especially more of that blood flow, bringing that to the area, and then that's going to be pro-healing instead of pro-inflammatory. So that's going to create then again some of those changes, along with kind of resting, relaxing more, running maybe a little bit less, taking some mileage off. Okay, so.
How long to foam roll for it to be effective in a given spot? You know, like the 2-minute stretch to actually work.
I kind of do that, like 2 to 5 minutes in that area, you know,
In
just
one
whatever.
given spot.
I would say, yeah, and again, you're probably not just laying on it where you're getting, you know, that whole, especially if they're doing the IT band, they're probably going from their hip down to their knee anyway, doing that whole area, or maybe then spending some time on the front of their knee and the thigh and the quad. So yeah, I would say like the 2-minute area, going over an area, you know, side to side, up and down. I mean, by all means, I will sometimes just, if there's one spot that's really painful, I'll just lay there and just try to take deep breaths and kind of suck it up for a few seconds, and then go on to some other spot, and then hope I didn't bruise my leg. So.
Are there any areas you say don't foam roll, like over bony prominences or anything like that?
Yeah, your body's gonna tell you. Like if you're having a lot of pain, you're probably over a bone or over a nerve. Those are the two places that your body's not gonna like it. So when you get over larger chunks of muscle like your hamstring, your quad, your calves, those are really simple areas to foam roll. But you're rarely. I have never had someone come in with an injury due to foam rolling. So it's a pretty safe. I don't want you to feel nervous about giving it out. It's really hard to mess yourself up foam rolling. You can do it. But you're pretty safe. Go with those guidelines. Hey, if it's causing discomfort or numbness, tingling, burning, then you got to back off. But as long as it feels kind of like a deep stretch, a little discomfort's okay, but not screaming pain going down your leg, then you're probably okay. Any other questions? All right, quick review at the bottom. This is at the end of all of our talks here. So if they're having the problem for more than 30 days, someone comes in, yeah, I've had hip pain. Oh, how long did that start? It's kind of yesterday. I don't know. Maybe I can get some shoes in here to clean that up. Probably gonna have some pretty good luck doing that. Within a week, 2 weeks, maybe. Anything over 30 days. Yeah, I've had this problem for more than 30 days. It's probably gonna need some kind of medical attention. Whether they get it or not is up to them. Like most people will not. They'll just kind of hope that it goes away. But those are some of the guidelines when you're asking them questions and interviewing them. If it's over 30 days, that's probably something that should be taken care of. If a change of footwear doesn't improve symptoms, so you guys have the tools to kind of fix the mechanical issues that are going on. You give them a pair of shoes, their pain goes away, great, you did your job. You give them shoes and it doesn't affect it at all, then that's again the inflammation has become too much for them to overcome with the mechanical corrections around the shoes. Tell them shoes, but they might need some other help there. And if the pain doesn't go away with like decreasing their volume. So if they completely shut it down and say, I'm just not going to do anything for like the next week and see what happens, sometimes that's very effective. If they have a healthy individual just kind of shutting it down, good luck getting a runner to shut it down, but sometimes they'll do it. And that goes away, then you're probably okay. You probably just inflame the tissue, give it another break, go back into it, you'll be fine. But if they shut it down, they still have the problem, which is like normal everyday activity, that's like a really big red flag that there's something going on they need to get taken care of. So you guys send them over to us, we give them a free screen. It's free, it's a pretty easy sell. Is there anything free in this store that we could, nothing's free?
Stickers.
Stickers?
Foam roller.
Okay.
Illinois.
Yep, so it's a pretty easy sell.
Advice.
Yeah, there you go. So it should be pretty easy to get people to come over to us to help them out. Anybody have any questions about that?
On the problem for more than 30 days, isn't it 7 days?
That's what we keep saying on the quiz.
Yeah.
So
7 days.
it's always
Maybe we're getting it
appropriate
wrong.
to send someone.
I keep getting it wrong.
Yeah, but when's the last time you had someone come in and said, yeah, this has only been going on for 7 days?
Very rare.
Yeah.
No, yeah.
Yep.
We
So
can still sell them shoes though, right? If they say 30 days.
yeah, you can always still sell them shoes. Yeah.
And some kind of apparel. So he looks good. He
And a
looks
foam
in.
roller.
And a
Yeah.
foam roller. Any other questions about anything? Guys, just because we're not coming back like the next time you do this doesn't mean you can't contact us. So you guys have our contact information. If you don't, then Sheena will send it out in an email. You can always come over to our office and see us and get checked out if you're having any issues.